Welcome to Srinetral. This is very hard cataract with mid-dilated pupil. This is a case which I have done long back, and I am being posting now to have some discussion about the few points which I have noted during this particular case. Mid-retic tried but did not work. As you can see, it has not dilated a bit even after injection of a phenylephrine. Staining of a capsule is very important in each scenarios, and that's why staining is performed. Staining usually takes 30 seconds, so you should give enough time to stain and then washed off with saline, and anterior chamber is formed with viscoelastic. A well formed anterior chamber is good, but do not overfill it and do not make it stony hard. This is followed by performance of a rhexis. Rhexis in such cases should be of a larger size, around 6.5 mm, so that you get more space for manipulation and chances for having a troubled surgery is decreased, because you get more space and thereby you can prevent any touch to the capsular margin, and you have more space. That way allow left hand manipulations better. Once the rhexis is completed, hydro is performed. You can feel that it is completed, both the sides hydro better, because in such scenarios you never know that many of the areas are very tightly stuck to the capsule. Once this is done, anterior chamber again is formed, and rotation of nucleus in such scenarios is very crucial. Though I know that in such cases the chances of having a posterior polar cataract behind is there, but without rotation such cataracts cannot be managed. So rotate them well. Once they are rotated, they are freed up from all attachments. Going with Phaco. Now here I am doing is debulking. Debulking is very important in such cases, because once we debulk, we have less amount of tissue to be managed behind, and cracking this nucleus is a skill. You can make a trench and leave behind a small area where you can cut it. The posterior plate is the strongest plate in the nucleus, so breaking it is very crucial, and it is the toughest too. So you must have a good hold. Go in depth. You know how much to go in depth. That should be very must know judgment for any surgeon. And once you see your tip is well depth inside, you have a good hold, and thereby you can start cracking the nucleus. You can see how easily we have got the first crack. Be careful, we can catch the iris as right now has happened, but if something like that happened, immediately take your foot pedal out. Again I am debulking and trying to make the third chop. This is a horizontal chop technique, so I go to the equator and divide it. As soon as I get a small piece which is free from all attachments, it is taken out, and now this is followed by remaining pieces to be taken out. Each piece separately take out to the iris level and finish off. This is totally unedited video. I am posting just as it is, and each piece to be separately divided. Do not make that every piece should be divided first and then only it should be taken out. Once we have a free piece, you take it out, because that way you will get more space in the bag for manipulations. So we are taking out each piece separately. This piece was not very well separated from the posterior plate, so I had a struggle to manipulate it. And once that is done, the anterior chamber is again formed with viscoelastic, because by this time your anterior chamber is almost nil with viscoelastic, and that cause more damage to the endothelium and PC will start coming up. So forming the anterior chamber in between is very crucial. Again I am going in with my dialer. Here I am using 1.5 mm dialer, which is slightly uh, steel dialer with a very sharp point in the front, which helped me divide this piece comfortably. If your machine is having many shallow chambers multiple times, then such kind of instrument should be very carefully used. So again I am dividing this piece into multiple small pieces and taking out at the iris level. And as soon as I am starting my Phaco, you may note that I am taking my left hand instrument to the side where I cannot damage the posterior capsule, or taking and making it slightly horizontal also. Though even taking out cataract is not always the success in such cases, anterior chamber is well formed, and now the time for a visco wash. If you are very comfortable in implanting IOL in such cases, at this stage there is no harm, because you may not have cortical material remaining much behind. And see, as soon as I am taking out the cortical material, the capsule is caught in my irrigation aspiration port. So I had to leave it slowly and make sure that I am not damaging the zonules more, and I'm just leaving it behind, and decided not to do interventions further and to implant the IOL first, because the bag is otherwise stable. Only small area I have caused a small zonular dialysis with my irrigation aspiration port, and here I am planning to implant the IOL. This is a single piece hydrophobic IOL to be implanted in the bag. So here goes the IOL inside, and I usually dial it with the help of left hand immediately in the bag. And this is followed by visco wash. So one thing we have noted, that even in such cases where we have conquered a very hard nuclei, not necessarily the bag is very safe, and finish off the irrigation aspiration procedure and implantation of IOL very carefully. Hope you enjoyed this case. Do subscribe to our YouTube channel Dr. Pankaj Lande for more such exciting videos. Thank you and good day.